Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, and welcome back to the MedEvidence podcast. I'm your host, Dr. Erich Schramm, sitting in for Dr. Michael Koren today. He's out on
maternity leave, right?
Maternity leave, that's right. It's my pleasure to be here with you. Just a little background for myself, for those who don't know me. I'm a long-term clinical research investigator and have been with the Encore Research Group for more than 20 years. My training and background is in family medicine. I'm a board-certified family physician and have been in primary care practice for more than 20 years. Though more recently, I'm specializing in cannabis health, so I help patients, guiding them on their journey for healing in the medical marijuana space. I'm very excited to be here with longtime clinical research colleague and one of my favorite dermatologists, Dr. Michael Bernhardt.
Thank you.
So Dr. Bernhardt and I go back a long ways. I recall the time that back in my residency training, he took me under his wing, had a great rotation as a family medicine resident in his clinical dermatologist office, and came away with a lot of practice pearls from that I still find useful today when I'm seeing patients. So that is greatly appreciated. Thank you so much. Mike has a great background in clinical medicine, probably 3 or 4 decades at this point, I think, and as well as thinking about his background in academics, recently teaching at Florida State University, the residents and the med students there. Is that right?
Correct.
Yes, sir.
Helped run a residency program for 3.5 years.
That's right. And also touching base on long-term clinical research experiences and background in clinical research. And I think that was going back to 2010. Is that right?
I've been here since I think 2008 or 2009. I remember we started doing some of the early phase 3 clinical trials for drugs, which are now almost fading out of the market, things like Taltz, Cosentyx, Silique, and some of the topicals. So we've been at this for a while.
Yeah, and that's actually, we'll be talking today. We'll sit down, we'll kind of do a psoriasis 101 discussion, really kind of drill down on some of those things. And we can talk about the treatments and kind of the evolution of those treatments, because 25 years ago in my training in your office, we really weren't talking about those kind of therapies because they didn't really exist at that time. So that's going to be kind of an exciting topic to get into. Anytime I'm sitting across the table from a clinical researcher, one of the first things I want to know is, hey, what got you interested in this and got you wanting to pursue research?
It's really kind of an interesting evolution because I started doing this, I think, in 2008, 2009, and a couple of things. I mean, back then, really up until the early 2000s, I used to call it institutionalized mediocrity in terms of how we treated our patients, because the therapies that we had were institutionalized, standard of care, they were garbage. I mean, literally garbage. All we had back then were drugs like methotrexate or cyclosporin, which are great drugs. They have the use. But in psoriasis, they were really suboptimal. Mm-hmm. And then around 1999, 2002, a drug called Amaviv came about, and it was the first injectable drug for psoriasis. And in the 15% of patients that it worked, it was a home run. People got clear. The problem was the other 85% didn't really do much. And then around 2004, somewhere around that time, Enbrel came along. Right. And Enbrel was a game changer. Right. Enbrel and Remicade were absolute game changers. They blocked an inflammatory molecule called tumor necrosis factor, TNF1. And at that time, we all thought TNF1 was the central hub that drove all the inflammation in psoriasis, which, of course, now we know is not true. And then when around 2008, 2009, when we had the big recession, I had people coming into my office who were literally facing foreclosure of their house, repossession of their cars. And when I started talking to them about some of these drugs like, Humira and Remicade and Enbrel, their eyes would glaze over because they lost their insurance, they didn't have money. And then by coincidence or out of serendipity, I was contacted here to become part of the research team. And you talk about a benefit, an amazing benefit for patients. We were able to give them state-of-the-art drugs. I mean, at that time, Taltz and Cosentyx were state-of-the-art drugs. And there was no out-of-pocket cost to patients. So not only were we able to use drugs that really delivered on the promise, I mean, people got clear.
Right.
Their skin became uninflamed. Their joints became uninflamed. Side effects were absolutely minimal.
Right.
And they didn't have to pay any money for it.
Right.
So we really accomplished a lot of good. And that's what really kind of was the hook line that got me into clinical trials.
That's a great story and some really important examples to talk about. Now, let's unpack some of that and let's talk. Give me a good definition for psoriasis so we know what we're dealing with here.
So, psoriasis comes from the Greek word psoare, P-S-O-A-R-E, which means to itch. And that's about the extent of Greek that I actually know. I don't even know how to say where's the bathroom in Greek. So it's challenging if I ever went there. But that comes from the Greek word psoare, which means to itch. And the irony is only about 20% of people with it actually itch. So we now know that unlike in the early 1980s, late 70s when I was in training, where they used to teach us that psoriasis was a condition from rapidly and proliferating keratinocytes, skin cells were growing too fast,
right,
which we now know is codswallop. It's an inflammatory disease, and it's really part of the whole metabolic syndrome associated with things like cardiovascular disease, non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. They're all kind of integrated with each other, psoriatic arthritis. So we know that. So all the people that I used to teach when I was teaching the residency program, they all know that I'm kind of what they call a cytokine geek. I like to really dive down and see what the primordial step is.
Right.
And we're getting close. We don't really know what the primordial step is in psoriasis, but we know that it's a consequence of inflammation. There are cells that are innate to the skin and that also circulate in the blood called dendritic cells. And they release a molecule, a pro-inflammatory molecule called interleukin-23. And interleukin-23 has a feedback loop relationship with other inflammatory cells and other keratinocytes, and it stimulates the release of interleukin-17,
right,
which really is like the analogy would be putting the key in the ignition and turning the switch, or for those of you who have cars newer than that and don't understand about putting a key in and turning a switch, putting your thumb on the start button and pressing it. And that starts the whole inflammatory cascade, which leads to skin proliferation. And since the skin is proliferating so fast and piling up, if you visualize a big mound of seashells, when you get to the top of that mound, it's got to go somewhere and it peels off the scale.
Right.
That's what
So
we see.
those very interesting because a lot of times people have that kind of question about how a condition that is systemic manifests itself at the level of the skin. So we're talking about an autoimmune diseases and abnormalities, immune system related abnormalities that result in a process that ends up being relating to the skin conditions.
Right.
So getting back to understanding, and you were saying at the top of the discussion, you mentioned a lot of the biologics involved, this kind of early development of the biologics and how they came in and why they ended up being real game changers in this. And so you've mentioned interleukin-23, interleukin-17 as important precipitators for this, and ultimately as they translate from that level in the dermis to the epidermis, and you end up with the.
It's hard to keep both of you using all those multi-syllable words there, Eric. Come on,
I know
it's Friday,
this is it's so interesting because right, and so. Truth is, about every Friday when we work together, I have an opportunity to pick your brain and be like, Mike, tell me a little bit more about, IL-17 23 and IL-17 and interferon 1 tumor necrosis factor. And, to trying to bring this down to, I always joke with him. I say, hey, look, you got to dummy it down for me. I'm a family practice doctor. So,
one of the smartest I ever met.
Thank you.
And one of the smartest I ever trained, by the way.
Okay. Thank you, sir. That's, we have mutual admiration society going. Thank you. So, I'm always trying to kind of think of this in terms of, really kind of the basic premise is here we have a very important immune system functions, but now we see what's I think fascinating about psoriasis is if you look at the approved therapies out there, they're hitting so many different pathways, and whether it's interleukin or TNF, you have phosphodiesterase inhibitors. And so it's such a diverse cascade of these inflammatory processes. And so you, as you alluded to, you had been involved in some of those clinical research trials. You mentioned Taltz was kind of very important and pivotal. And the other thing that's interesting, I think, in these medications, you start to see this evolution. They went from injectables. And then at some point, maybe you could talk about some of the JAK stat inhibitors out there, and understanding, hey, these treatments went from injectables to orals. That was a big leap in being able to offer oral medications to patients. So maybe you could touch a little bit.
On that. It's funny, Eric. Everything goes in cycles, and prior to the onset of the biologic age, which primordial era was Enbrel and Humira, but the modern era probably started with Taltz. And, our site, we had like 40 patients in the study. So I had hands-on experience with over 40 patients on Taltz before the drug ever came to market. So I was always very comfortable with it. But now we're gravitating back into an oral realm. There's an oral IL-23 inhibitor in development. Phase 2 studies have been published by Johnson & Johnson, which looks like it's going to be an amazing drug. The JAK inhibitors are an amazing drug. So one of the things that I try to impress upon people, like there's a difference between autoimmune and autoinflammatory. And I think psoriasis is probably more accurately conceptualized as autoinflammatory rather than autoimmune.
Can you tell me a little bit how you define that difference?
In other words, you get inflammation rather than autocritic destruction. So in psoriasis, you're upregulating a huge inflammatory cascade, right, rather than tissue-targeted destruction. So that's why I tend to think of it as autoinflammatory. One of the ways I try to teach when I'm teaching residents, either dermatology residents or internal medicine or family medicine residents, is when you're thinking about the immune response or the inflammatory cascade, all the things that you see, everything is done so linear. 23 leads to 17, leads to this. I tend to think of it as a series of interlocking gears, where one primes the pump for the other and allows other processes to turn on. And I think that, I think some of that, the linear aspect of thinking about this is just, I think, part of a fundamental limitation of human thinking, that we can only think at one thing at a time. But with autoinflammation, you got to think of interlinking parallel gears. And a lot of these, I call these autoinflammatory cytokines, I call them the usual suspects. Because if you look at a lot of diseases are using the same pathomechanism in different body parts, right? So there's data that shows that ulcerative colitis and Crohn's disease is driven by an interleukin 17-23 cascade. There's data that shows that multiple sclerosis, is driven, the experimental model for that is driven by interleukin 23. There's some data that I read in one of the throwaways where terrible diseases like ALS may have an IL-17 derivative to it. So a lot of these usual suspects, these evil suspects, and they're not really evil, but the effects that they do are evil, pop up in different areas because these were originally designed to fight certain things off. And what happens is there's either a genetic or an environmental miscue that ramps this system up. So if you think about the inflammatory process, I used to use the analogy, It's like thinking about NATO and the Warsaw Pact. You have two armies head to head. And on one side, you have the interleukin-17 AF derivative, which is designed to cause inflammation. And then on the other side, you have interleukin-10, which I always say is kind of like Snoop Dogg. You know, give them a joint, cool them out, chill them down, let them go to sleep, and let them stop being inflamed. So these two are butting heads. And when there's active inflammation, 17AF wins, IL-10 loses. When that inflammation's damped down, IL-10 wins, 17AF loses. So there's always that kind of push-pull going on in the body. And the question is, what's driving it? Why does it happen? We don't know why it happens in psoriasis. We do know that psoriasis is a genetic condition. It can run in families. Two of my brothers had it. My mom had it. What can set it off? A lot of things. Stress, alcohol consumption, certain medications, particularly beta blockers, can trigger it. Trauma, injury, and sometimes Rule 17, which is stuff happens. Mm-hmm. And it just kind of happens. And back in the old days, before we were in the modern era, you know, counseling someone with psoriasis was very discouraging because all we had was topical steroids and maybe methotrexate. Cyclosporin you couldn't use forever because you had to watch blood pressure and kidneys, as you know from being an internist. So we had limits on what we could do, and it was very frustrating as a physician to do the best that you could and know that you're only going to get these people marginally better, right? And then when the Taltz and the Cosentyx phase 3 pivotal trials came out, they were huge because for the first time ever, we were getting PASI 100s. And for those of you who don't know what a PASI is, PASI stands for Psoriasis Area Severity Index. And what we do is, through a very tedious process, we quantify how much of the body surface area is involved with psoriasis, how thick the plaque is, how severe the scaling is. And we kind of cook that up and boil that into a number. So a PASI of 2 or 1 is good. A PASI of 20 is very bad. And in the old days, when people had these high PASI scores, topical steroids would only go so far. Now with these injectable biological drugs, whether it's Taltz or Cosentyx or some of the 23 inhibitors, the norm is to see people clear or almost clear. That's the norm. And the beauty of it is that that visit has been reduced from a 30 to a 45-minute visit that mostly consisted of hand-holding to, gee, you're great. Are your labs up to date? See you in 6 months. Any problems from the drug? No. See you in 6 months.
Wow.
You know?
So they really hit a home run.
It's a grand slam.
Pharmaceutical industry
Bases loaded, bottom of the ninth, grand slam.
Right. So the other day, it was interesting. You were in the office and you were talking to one of the coordinators, and you were showing them your hand and said, talking about body surface area. So what's the significance of the handprint?
It's a peace sign. So usually when I can't split my fingers like Spock used to do. But no, usually you use the patient's hand, and it's not really the whole hand; it's the palm. Use the patient's palm as an indicator of body surface area. So one area the size of the patient's palm should correspond to 1% body surface area as a rule. Right. And that's what we use. We use the palm. Now, in real practice, most patients' hands are about the same size unless you're talking to someone, you know, like maybe one of the guys on the Jags or one of the professional basketball players. But for most normal people, most mere mortals like us, most palms are about the same. So we all kind of use our own palm in clinical practice to get an idea of what their body surface area is.
So for those patients, suppose that they don't meet the criteria to consider the newer therapies, biologic or one of the DMARDs or something like that. What do you have to offer somebody that isn't that severe?
So there's gradations of severity, right? And the standard is typically how much body surface area there is. Now, the other things that you have to think about is areas of involvement, not just body surface area, scalp involvement. Do they have scalp involvement? Why is that important? Because people with scalp involvement have 4 times the risk of developing arthritis from the psoriasis as people without it. Do they have little pits in the nails where it looks like someone took a safety pin and tried to chisel a hole in their nail? Well, if the answer to that is yes, it means they've got what we call matrix disease. And nail matrix disease is 3 times more likely to develop psoriatic arthritis as the rest of the population. So those are areas of special interest, and that's the reasons why. The other area, facial involvement or genital involvement. Facial involvement, people feel marked. They feel like lepers. genital involvement involves, it impairs psychosocial function, impairs relationship formation. So for people with those areas, even though there's limited body surface area, we still, in the AAD, they still consider that an escalation basis to ramp that up as a severe disease. No. And then I'd be more aggressive with them. People that don't have those areas, that maybe have 3, 4, 5% body surface area, there are a couple of oral drugs out there. Otezla is one, which is a phosphodiesterase inhibitor. Typically, how does a phosphodiesterase inhibitor work? Long story short, it indirectly decreases tumor necrosis factor 1. Okay, it affects cyclic AMP and cyclic GMP and cyclic AMP and ATP formation, but the end run is that it decreases TNF inhibitor.
Right, and that can be combined with other modalities, right?
Yeah.
So
topicals, you can use it with topical steroids.
Whether you're inhibiting interleukin or
and it's a great drug. It's definitely got its place. I think we're looking at doing a clinical trial on a TYK2 inhibitor, right, which is tyrosine kinase, which is one of the inflammatory systems, and those work really well too. I mean, there's one tyrosine kinase inhibitor already on the market, but we're looking at a competitive one for clinical trials. So it offers a nice alternative because there are some people that don't want to inject themselves.
So with the new drugs coming on the market, what would you like to see better in terms of these new medications? What would you like to see improved upon?
Boy, that's a tough question, because now if you'd asked me that 10 years ago, I'd have given you a laundry list, But now, I mean, if we can achieve the same thing with an oral without having to self-inject, I think that would be very nice. Okay. Although I take Repatha and I pinch a big roll of fat, which I have way too much of, and click it, and it's really not a big deal.
But you're working out. I see that.
I know.
It's looking pretty good these days,
I work
Mike,
out, but it's like, gee, I've worked out. Now I can eat 10 pieces of chocolate. It's the whole cycle balance. But so if we can achieve the same things orally that we do with injections, I think that would be beneficial. Now, you were talking about the JAKs before.
Right. That was kind of where I was leading to, is, what kind of issues were there with those, with that particular class?
I mean, the way I think of JAKs, I think of them as the prednisone of the 21st century. They do a lot of things that the steroids do. JAKs, so the intellectual basis for JAKs is every cell has a receptor, right? The psychographic for that is, if you think of putting a straw in a cup of chocolate pudding. All right, the chocolate pudding is the cell. The straw goes in. That's the intracellular environment. The part sticking out acts like the receptor and binds some of these cytokines. So let's say a cell receptor binds to a molecule of interleukin-23. What happens next? Well, there's what I call an inflammatory synapse, just like we have neuromuscular synapses. This is an inflammatory synapse where the receptor binds. There's like a little impulse of transmission that goes down through the receptor, through the membrane, into the interior of the cell. And that transmission fires off a stimulation of these JAK, which is Janus kinase molecules. They're enzymes.
Right. They're like little machinery factories, right? They're
when those enzymes get tweaked, they cause stimulation of the second phase of that, which is the STAT. STAT complex, and when these STATs get activated, they then transmigrate to the nucleus and upregulate inflammatory genes. So if you stop the JAK, you stop STAT, you stop inflammation.
So really treating it right at the core.
It's a big, the JAKs are more like a shotgun than a sniper rifle. So the 23 and the 17 inhibitors are more like a sniper rifle because they're picking off the specific cytokine. The JAKs are a broad shotgun, and they just shut down everything.
Well, I think, in terms of the interleukin inhibitors, I think it's being a little more downstream, right? Versus if you're arresting that at the point from a cellular level, right? So you're just shutting it down at the cellular level.
For example, JAK1, right? JAK1 upregulates a variety of cytokines, right? Things like interleukin-3, interleukin-5, interleukin-7, interleukin-9. So those all get upregulated, and they all have specific functions, like interleukin-7 is a broad T-cell stimulator, right? Interleukin-9 upregulates killer cells. Interleukin-15, right now I'm just blanking on what 15 does. But so you're down-regulating a huge inflammatory cascade.
Right.
Right. Interleukin-2 is responsible for driving interleukin-6, which is one of the main pro-inflammatory cytokines for a lot of tissue destructive.
Right. So kind of the pros there are broad suppressant of these wide range of inflammatory molecules.
Right.
But the downside is there could be collateral damage in that, right? And that
Just true
whether
with
it's
any-
immune system or whether it's infection or
That's why these
those
drugs
kind of
aren't on
things.
the candy aisle. I mean,
Right,
drugs
right.
are drugs, and they can cause great things. They can do terrible things. So I was doing a lecture last night to some other doctors. I said part of our job as learned intermediaries is to be able to figure out what drug is going to be in such a state where we've mitigated the downside risk and maximized the upside potential. That's our job as physicians, and that's why I don't think AI will ever really replace a good physician. You know, even though patients come in all the time, Dr. Google said I had to do this, 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 and this. I said, well, Dr. Google's office is right next door. Feel free to go see him.
There you
This
go.
is how we're going to do it here.
That's right. No, I appreciate
But
that.
the Jackies are great. I mean, they're a brave new world. A lot of people have developed what I call jackophobia. They're afraid of the jacks, and that really bothers me. And the reason for that fear was there was a study. There was a problem with Xeljanz about 12 or 13 years ago. Xeljanz is a pan-JAK, JAK 1, 2, and 3, which blocks everything. Okay, it's a great drug, and it has its use. But there was a cohort of patients with rheumatoid arthritis who were on comorbid prednisone and methotrexate, and they were using a dose double what we're using today. And there were some problems. Some patients had pulmonary emboli and deep vein thrombosis. And then about 4 years ago, there was a study where they compared one of the TNF inhibitors to Xeljanz in the same cohort population, methotrexate and prednisone-treated rheumatoid arthritis, and they showed that there was what they call they were not able to establish non-inferiority. Okay, so they couldn't say that the JAK was non-inferior. Granted, everybody listening, I agree, it's double talk, but that's just the way these things are done, and this is done via bureaucratic methods, not our methods. But it showed that there was quote-unquote non-inferiority. So now the entire class of JAKs have this box warning about infection, lymphoma, deep vein thrombosis, and cardiovascular disease. Yet when you look at these newer drugs that are not pan-JAKs, that are selective for just JAK1 or maybe JAK1, JAK2, the data doesn't reflect the warning, at least not the data that I've seen.
Okay.
Reflect the warnings. Now, if someone comes to me who's got a history of deep vein thrombosis, or they have some of the metabolic syndromes that predispose them to blood clot formation, probably not a great choice, right? I'd go in a different direction. But for a lot of these other diseases, these JAK inhibitors are going to be the cat's meow.
That's great.
Yeah.
And thinking about those patients that were on prednisone and methotrexate, which
of course have no side effects at all.
Yeah, I was going to say we're
totally benign drugs, totally harmless, nothing to worry about.
So that puts it in the context of what we think about, and I think it's great to have someone with your clinical experience and your research experience, so that you can take and give kind of a real risk assessment for patients and say, and in doing the right thing for your patient at the end of the day.
And the problem, Eric, is and you and I have both dealt with this in our practices. There's risks of taking the drug, but there's risks of not taking the drug. I'm not a rheumatologist. I don't treat rheumatoid arthritis, but I have a lot of patients with overlapping syndromes. And the inflammatory environment is different in rheumatoid arthritis. It's more interleukin-1 driven, rather than interleukin-4/13 like in atopic dermatitis, which is where we use most of our JAK inhibitors. And in atopic dermatitis is our big use for that particular drug. It's a different pro-inflammatory environment. They don't have interleukin-1 upregulation. They have 4/13. So the risk for that population of having a vascular event is really pretty low, probably no more so than the SEER data, which is the expected population-based data.
Right. So your take on the type 2 tyrosine kinase 2 inhibition, some of the newer products here being developed, what's your comfort level with that?
Very. very comfortable. There's one on the market that I've been using in patients. Like I said, there are some people with psoriasis who don't want to take a shot. So there's one of the TYK2 inhibitors is on the market, and I've been using that for a couple of years. And it's a little slower in onset than the shots. I can tell people it's the tortoise, not the hare. But at the end of a year, you're basically going to be in the same place, just going to get there a little slower. Knock wood, I've not seen any significant side effects to the point where patients would stop using the medication.
Yeah.
And it works.
Wow. That's great. So, I was thinking about this because I'm a big college basketball fan, and watching March Madness. And
oh my God, go Gators! What a great
year for them. Gators! There you go. And what struck me,
and Auburn and Houston and Duke, all the teams that made it to the Final Four.
Give them credit for that. They were a great series. Great. There are a lot of great games there. But what's really interesting were the commercials, right? And so I was surprised at the number of commercials for psoriasis, and the selling point for this one particular drug was it tackles or treats both types of interleukin-17, and I was like, wow, that is a really sophisticated advertising approach to direct to consumer advertising. That's very sophisticated. And so curious, do patients come in, saying, hey, I saw this commercial on TV blocking both types of interleukin-17. Have you seen that in your
I'm waiting
practice?
because I want them to give me a lecture about it and tell me that. What actually is kind of funny is, like I said, I'm a pathways geek, right? So what I was doing this morning in between surgical patients, there was a great article published this month in the British Journal of Dermatology where they did a genetic analysis of hidradenitis suppurativa. And they looked at all 5,000 genes that are upregulated in hidradenitis suppurativa. And they found that there was we've always known that there's more 17F, both in the lesion and perilesional, right? And F is a very powerful driver, and I'll talk about that in a second. But in this study, they looked at the gene sequencing, and they found that not only was 17F upregulated in the follicle itself, but in the perilesional dermis, those dermal fibroblasts were kicking out more 17F. And so 17A, we already talked about. It's released by dendritic cells, stimulates the whole 17A loop amplification, right? 17F seems to be more tied in with upregulating other players in hidradenitis, like interleukin-1, which the whole interleukin-1 family is a very strong pro-inflammatory cascade, upregulating interleukin-8. Now, interleukin-8's job is to cause neutrophils or white blood cells to migrate into the lesion. So they're taking the position that hidradenitis, and I think I agree with this, hidradenitis is primarily a neutrophilic dermatosis. And it's a biphasic disease. So it starts out as a pro-inflammatory disease. They know that there's a defect of this gene called secretase. And gamma secretase is important in the hair shaft and allowing the hair to turn into hair. When it's defective, it forms cysts. And that seems to be ground zero for HS. They form these inappropriate cysts. And the other thing that they've found is through a process called epithelium-mesenchymal transformation, where cells go from one cell to another type of cell, kind of like what we see in cancer. In hidradenitis, fibroblasts will transform into epidermal keratinocytes within the dermis, which also drives inflammation.
Wow.
So IL-17A and F get massively upregulated in hidradenitis. And the beauty of this new drug, by downregulating F and the AF heterodimer, is you can drive down that interleukin-1, TNF, interleukin-6 cascade. So that's why that particular drug has been successful in treating something, not just psoriasis and psoriatic arthritis, which it's great for, but I think also for treating a previously very difficult disease to treat, which is hidradenitis suppurativa.
Well, I think I hear the topic of our next podcast discussion coming up, right? I think that's going to be in a couple of weeks.
Skin is in, baby.
Yeah, I never get tired of hearing you talk about about the inflammatory cascade. So
It's amazing.
So, Mike, thank you so much. Give a ton of insight there. Always appreciate that. And, whenever we can talk about science and Snoop Dogg and all of that, and so I love picking your brain on things.
My pleasure.
Any question you think I should have asked you?
Well, let's see. For those of you who are really on the edge of your seat, I found a great restaurant down in St. John's.
Do tell.
It's called Irons and Ember.
Okay.
And they do all their cooking is in cast iron skillets. Everything is fresh. The seafood is fresh. The prices are reasonable. The service was great. We went there 2 weeks ago, and it was the kind of place where my wife and I looked at each other and said, when do you want to come back? And I'm like, how about tomorrow? So the big unanswered question, where should we go to eat this weekend?
Okay. That's great. Well, no, thanks for your insight as always. And, again, look forward to talking to you in the near future. We'll pick up on hidradenitis suppurativa, right?
It's an amazing disease state.
Thank you.
Thank you.
Thank you.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.